Good afternoon. We have today here with us Professor John Cleland, who is the Professor of Cardiology at the Imperial College of London and also the Royal Brompton Hospital and Glasgow. As you're all aware, he's a celebrity in formulating the guidelines of heart failure of ESC. He is the person who founded the European Journal of Heart Failure, and he's on the editorial board of Journal of American College of Cardiology as well. And it's a proud privilege, sir, for us all. It's an honor for you to be here in this conference to share your knowledge, your wisdom, and your experience with us, which will help all clinicians, we cardiologists, physicians, and also the patients at large to help them, help us treat them better and help them treat themselves better. And I welcome you here, and I would like you to share your experience here with us and also to tell us your recent achievements in the field.
Okay, well, thank you very much for that flattering introduction. One of the things you forgot to mention is it's an opportunity to come here and meet many friends. Many people I trained with in cardiology over the years in the UK have come back to India and continue to practice here. And even one or two British physicians have actually emigrated to India and are now working over here. So not just Indian trained physicians coming to the UK and coming back again, but actually we're now going into more of an exchange rather than the old relationship. So that's quite interesting. And I think we have a lot to learn from India. It's a huge population, a huge country. Its health service is in evolution. And it's very interesting for us to watch and see you hopefully not make some of the mistakes we made, but either make your own or just make success. In terms of the work that I'm doing, I now work between Imperial College in London and the Royal Brompton and Glasgow. Glasgow is about an hour's flying time from London. I'm the director of biostatistics and clinical trials unit there. And so why was I interested in that job? Well, for many of us, we work with clinical trials, but the clinical trials we get are the ones that we negotiate with the pharmaceutical or device industry. And ultimately, it is about proving some concept that they need to prove for their treatment. But we as doctors, we should also have our clinical trials that are not done to find out whether the drug works, but to find out whether the patients benefit. And those might sound the same, but they are subtly and importantly different. So in taking up this new job, it gives me the opportunity of actually creating clinical trials that are investigator-led, and we actually have patients on our steering committees, and the patients help to design the clinical trials and run the clinical trials and make sure that they're relevant both for patients as well as the doctors who are looking after the patients. In addition to that, we're having an initiative into the global epidemiology of heart failure. We see registries in many countries and also administrative data. It's often very difficult to compare the outcome of patients across different countries, and we've developed quite sophisticated statistical techniques that allow us to adjust for the risk across different countries, so we can start to compare outcomes of patients in different healthcare systems. And that's already led to some very interesting data. So first of all, we compared the British outcome to the American outcome for hospitalized patients with heart failure. And we find if you just take the raw figures, the British patients do much worse, 2 to 3 times the inpatient mortality that they have in the United States. And you might say, oh my gosh, that just shows how bad the NHS is and it's not very good. But actually, when you take a risk score, you find that the patients being admitted in America are really not that sick. They have a very low threshold to admitting the patient to hospital, which is why I think they're able to discharge so many of the patients so quickly. And when we adjust for the American risk, the risk in the British patients is exactly what the American data would have predicted. So all of this is just how easy or difficult is it to get into hospital. In the UK, we have very good community services, so patients are usually managed at home until a certain point where it's felt that the home care system can no longer manage, and then the patient's admitted. Whereas in America, it seems that admission is the first resort. If a patient, something goes wrong, there isn't really a great community service, so they're admitted to hospital. But then we turn to our Japanese colleagues to do the same, and the Japanese have an even lower risk of inpatient mortality than the Americans. And when we adjust for that, we do find that there's again a very low admission threshold for the Japanese patients. But even accounting for that, they do much better than either the Americans or the British. Now that might be because the Japanese are genetically different, and which the Japanese certainly think might be true. But I wonder whether there's a simpler explanation, which is British patients, they're quite friendly with the doctor, and sometimes they take the advice and sometimes they don't.
Don't take that advice.
Whereas Japanese patients, I think that they take it all much more seriously, and when the doctor tells them to do something, they do it, and they do it very precisely and accurately. And it may be that the reason for the better outcome of the Japanese patients is just a different cultural attitude to the relationship with the doctor.
Could it be that the so-called stable patient with heart failure in US is near the targeted dosages, and yours and Japanese are not near the target dosages, or something like that?
Well,
because in India we find a great reluctance on the part of the patients and also on the part of the physicians to escalate doses every visit. So what do you think are the roadblocks in reaching the guideline-based targeted doses of ACE inhibitors, beta blockers, or even MRAs for that matter? MRAs are seriously underutilized in this part of the world as well. So what do you think are those roadblocks?
Well, in the UK, we've trained a group of heart failure specialist nurses, and the doctor will give a prescription or a trial clinical management plan, but then they give that to the nurse, and the nurse then will see the patient and titrate the medicines. We think we're quite good in the UK, but it is patchy, that some services are very good, other services struggle, and but I think that there is another shift. So many of the patients in clinical practice are older and frailer and have reasons that they don't get into clinical trials. Potentially they have more to benefit from medicine, because if you're sicker, perhaps medicines make a bigger difference. But their ability to tolerate these large doses may be different. Clinical trials have to take a very simplistic view of the world, usually, and they go for a target dose. Whereas what clinicians do, I think, is they look at the physiology and the pathophysiology of the patient. So, for instance, beta blockers, you might say, well, I titrate the beta blockers to target dose. And that's what I used to do, and that's really what the guidelines tell you to do, but it's actually no longer what I do in clinical practice. What I do in clinical practice is I titrate to achieve a beta blocker, to achieve a heart rate, target heart rate. So, and that becomes quite interesting, because you actually end up probably using, on average, higher doses of beta blockers than you do the guidelines suggest. For a patient in sinus rhythm with heart failure due to a reduced ejection fraction, I try and get the heart rate down between 55 and 60 beats per minute is
That's very interesting.
is my sweet spot for sinus rhythm. For atrial fibrillation, it seems to be somewhat different. There's a very different relationship between heart rate and outcome there. And I'm very cautious now about using beta blockers in patients with atrial fibrillation. We like to control the heart rate, but my ideal heart rate for somebody in atrial fibrillation and heart failure with reduced ejection fraction is between 75 and 80. So that means I'm using much smaller doses of beta blockers in the atrial fibrillation patients than in the sinus rhythm patients. Now, is that the right thing to do? I'm not sure that the evolution in thinking is complete. For sinus rhythm, it's pretty clear. For atrial fibrillation, as we'll give a lecture this afternoon, the situation looks a bit more complex. And it may be not only the dose, but how quickly you achieve the dose. What we're finding is that when you initiate a beta blocker in a patient with atrial fibrillation, there appears to be a period of risk.
Yep.
That they actually have an excess mortality from a beta blocker. And I think that may be because of too rapid titration. So I now go quite low and slow with the beta blocker. I'm not keen to reduce heart rate too much. What we find, so a number of analyses have been done, one of them suggesting that there isn't any benefit from a beta blocker in patients with atrial fibrillation, although it appears safe but not beneficial. It is the best evidence safe drug for controlling heart rate in atrial fibrillation, so we certainly should be using beta blockers in some dose for the vast majority of patients. When we look long term though, if we discount that early period of risk, it does look as though there is a large benefit long term in atrial fibrillation. So we have a sort of crossover effect with an early period of risk followed by a long period of benefit.
So in a stable patient, let us say a patient comes out of the ICU, right? And you institute, the patient is now fairly dry, he's not breathless, there are no rals. You institute an ACE or a beta blocker. Now here, there's always a dilemma. Should I up-titrate beta blocker first or up-titrate ACE inhibitor first? That's the first question.
Yeah.
And when to add a mineralocorticoid receptor antagonist, provided potassium permits, of course.
Yeah. So in these circumstances, a patient who's had a recent decompensation, we would be unhappy if the patient didn't go home on a combination of I'm going to say an ACE inhibitor for convenience at the moment, ACE inhibitor, MRA, and a beta blocker. So this is assuming their heart failure with a reduced ejection fraction. I titrate the ACE inhibitor quickly, assuming the blood pressure and renal function are okay.
Yep.
The mineralocorticoid receptor antagonist, I put them on 25 milligrams, and basically we won't be moving the dose of that unless the potassium goes too high or the potassium's low and we need to get the potassium up. And again, we talked a little bit about heart rate, so we should also talk about potassium. The ideal potassium is 4.5, and it should be between 4 and 4.9.
Yep.
So, and again, you can titrate the MRA to try and achieve this optimal potassium. The beta blockers I titrate much more slowly. Does depend a little bit on heart rate. If I got somebody like your patient who now looks dry and comfortable, but they still have their in sinus rhythm at 100 beats per minute, I would be tempted to titrate the beta blocker a little bit more quickly. If the heart rate is already down at 70 beats per minute, then I can wait.
Might as well go slowly.
Then I can go a little bit more slowly.
Yeah.
So I think titrating these drugs to physiological targets to me makes more sense than just going for a dose.
Sure.
Dose gives you a rough idea of where you're going, but the heart rate and the potassium will tell you much more precisely what dose you need.
Yeah, thanks for that. That was a very good advice.
Yeah.
Now, the next question is,
I
we
should,
got
I
Arnie.
should just say, well, Arnie. Are you going to come to Arnie?
Yeah.
Yep, go on.
Yeah, we have been introduced to Arnie recently in this country, and the biggest question now we have a decent amount of experience with this drug. What is your opinion about Arnie use in ACE naive patients?
Yeah. So.
And how early after the patient comes out of the ICU, could you start Arnie straight up ahead of ACE inhibitors?
Yeah. So, just recently, a study was presented at the American Heart Association, the Pioneer HF study, and in that study, 35% of patients had new onset heart failure, so they'd never been treated for heart failure before. 65% had a previous history of heart failure. I can't remember exactly, but I think only about half of the patients had been treated with, in fact, I think it was only 40% had been treated with an ACE inhibitor, maybe 20% with an ARB prior to that admission. And they randomized the patients to initiation of Arnie or enalapril, and basically showed that within 8 weeks, which was the primary endpoint in this study, and it was a mechanistic study, so it was looking at natriuretic peptides, but in addition they looked at serious adverse events, and if you look at the composite serious adverse events, they were significantly more with the enalapril group than the Arnie group. So the patients with the Arnies were there were fewer deaths, not many deaths in the study. I think it was 10 versus 5. There were fewer rehospitalizations and generally seemed to be better outcomes. So I think the Pioneer study gives us the first hint that going straight to an Arnie is the first option.
It gives us some confidence.
Yeah.
But would you wait maybe for 3 days or at least 4 days till the hemodynamic stabilizes, or let's say the patient has just come off the ICU?
Yeah.
And what is the earliest window you can think of?
Yeah. So I think we're gaining experience in this area as well, and so if a patient has good renal function, the blood pressure is okay, then I would have no problem about starting them straight away on an Arnie. If the patient has problems with major renal dysfunction, hypotension, then I'm inclined to think about either an ACE or an ARB to begin with. Why do I even mention an angiotensin receptor blocker? The answer is, well, if I want to switch straight from one drug to the other, an angiotensin receptor blocker, I can just do a straight switch. If I have to switch from an ACE inhibitor, then I need to wait 36, 48 hours between dosing, and that's sort of a bit messy in this situation. So still a little bit cautious. In a very unstable, delicate patient, I might want to go in with an ACE or an ARB first, stabilize the situation along with the beta blocker and the MRA, and once the patient's a little bit more stable and I'm comfortable that I know how much trouble they've run into with low blood pressure and renal dysfunction on the ACE or an ARB, then you can think about switching to the Arnie. But for a patient who is more straightforward, then providing you've got the reimbursement and everything else, seems smart to go down that route. When it comes to outpatients, I must admit that we go more along the European guidelines rather than the American guidelines. We have many patients who come back to our clinic and we measure the NT-proBNP and it's only mildly elevated, NT-proBNP of 200, 250 nanograms per litre. We've looked at those patients in our clinic. The likelihood that those patients are going to have an event in the next 5 years is really low. They do very well. They have responded to treatment, and if you've responded to treatment, why do you need to change? So, at least in our setting, it's much less expensive to measure NT-proBNP than to start Entresto. Also we find with patients that a patient comes in, and says, I feel fine, and you measure the NT-proBNP and it's maybe 1,000, and you think, well, the patient isn't fine. When you have the conversation with the patient, you've got something to back you up and say, well, you may feel fine, you may say you don't want to change, but I can see in your tests that the disease is not controlled and you should have something more.
Yeah. But probably, is it not true that NT-proBNP in a stable patient, so-called, NT-proBNP would give a guide that you still need up titration of the therapy?
Yes.
If I'm saying that, am I correct?
That patient has a continuing substantial risk. And that I think will be modified by the RNA, not maybe, but will be.
Yeah, one more question is that stable patients with heart failure, NYHA class 2 and 3, as we know from the literature that they die more of sudden cardiac death than heart failure. Now, in my country, we can't subject all of them to assess for the risk of sudden cardiac death. So those who come in class 2 and class 3, which of them I should evaluate for the risk of sudden cardiac death?
Yeah. So I think that the defibrillator is optimally used in a well patient with a bad ventricle.
Yeah.
So when you see that oddity, when you see a patient who's looking really well, but the ventricle looks horrible, those are the patients that I think benefit mostly from an ICD.
Yeah.
In the Scudheft study, which I think is the best of these studies, if you were an NYHA class 3 or worse, there was no benefit from a defibrillator. Those patients, I think the heart failure has gone too far, and we've seen this in other clinical trials in revascularization. If you look at revascularization, if you look at statins, if you look at the recent Commander HF study with rivaroxaban, in each of those situations, in the milder patients, the NYHA class 2 patients, there seems to be a benefit. But in NYHA class 3, 4, the sicker patients, you lose the benefit. So I think it's the same with defibrillators. If we look at the bundle of evidence, then an ICD also works better in people who have an ejection fraction less than 30%. So if you're in class 2 with an ejection fraction less than 30%, you really should be thinking about a defibrillator.
Does here, by any chance, soluble ST2 gives you some idea about the prognosis and the risk of sudden cardiac death? Because even RNA reduced.
I've read the papers. I don't have any personal experience of that, but I think it is fascinating. I think,
You don't recommend that?
Well, we don't use it, so if we haven't used it, and I don't think the evidence from the literature is all that compelling. I think it's an interesting story. It may be true, and if you're interested, try and stimulate some research that will convince us all.
Thank you. And one last question. Many physicians in this country, to get to the target dose of RNA, down titrate the beta blockers, or shift from carvedilol to bisoprolol, or stop the beta blocker altogether and shift to ivabradine to get the margin of blood pressure so that you can uptitrate the RNA. Now, is this wise thing to do? I have my own reservations about that. Is this a wise thing to withdraw beta blocker to get to the target dose of RNA?
No, I think that's a very bad idea. First of all, we've got growing evidence from the RNA trials that even if you don't achieve the target RNA dose, there does still seem to be a benefit. So if the patient can't do that, then don't back off the other treatment. With some caveats, I've said already about atrial fibrillation, that I think it is okay to back off on the dose of the beta blocker and allow the heart rate to rise a little bit. For the MRA, I think that you can optimize the dose of the MRA to fit the potassium, try and get the potassium as close to 4.5 as possible. But the big class of drugs that you could think about is, especially in an NYHA class 2 patient, a relatively mild patient, are the diuretics. And So trying to...
So that we always
Yeah,
down titrate.
yeah.
Yeah. So
if you
that's
down
very nice
titrate
to
the
hear from you.
diuretic.
Thank you.
Yeah.
And one last question now. Do you think heart failure with preserved ejection fraction, HEPF, and heart failure with reduced ejection fraction, HEPREF, are the continuum of the same disease process? Or they are two different entities with two different disease processes?
I think that they're predominantly two different disease processes. It doesn't mean to say that some people can't have both.
Yep.
So, you could have a hypertensive heart disease with HFpEF, and then they have a myocardial infarction, and they then have a mixture of HFpEF and HFrEF. So I think we get these mixed populations, but I think by and large, yes, they are. And I think the easiest way to think about it is with the HFpEF, you're thinking about hypertension and maybe amyloid now these days.
Yep.
So thinking down that route, these patients often have CKD, atrial fibrillation, and history of hypertension. Whereas the HFrEF group tend to be more dilated cardiomyopathy, ischemic heart disease. Some of them, yes, they are hypertensive.
And I think cardiac MR has made a lot of difference in our understanding of the underlying disease process in HFpEF patients. So many of HFpEFs you have now been able to diagnose as sarcoid or amyloid, which we were completely missing in the past. So I think
yes, I think that's right. And of course, there wasn't really a reason to get terribly excited about diagnosing amyloid because it was a bit of a death sentence.
Yes.
But now we have a drug, albeit far too expensive even for the US or UK healthcare system, tafamidis. But hopefully the costs will come down. This is an extremely effective treatment for one form of amyloidosis, the transthyretin amyloid.
Thank you very much, John. It was wonderful to be having with you. Pleasure.
Yeah,
Thank you.
lovely to be in India.
Thank you.